The Achilles tendon, as we all know, inserts into the calcaneus from the triceps surae. We can see ultrasonographically the perfect correlation it has from a diagnostic point of view with its most superficial tendinous part, the deeper muscular part of the soleus muscle, and the differentiation in the superficial compartment that clearly distinguishes it from the flexor of the hallucis in depth. It also has a very clear rotational aspect that gives it increased resistance, exactly like the hem probes of a ship. From the point of view of injury, it has a clearly poorly vascularized area between the more richly vascularized proximal and distal areas, which is the weakest zone where most ruptures occur between 2 and 7 centimeters from its insertion. The diagnosis of rupture is usually relatively simple, just the act of compressing the calf. We see that in one place it produces tension, and in another place, however, it does not produce any tension. This is the typical Thompson test. It is also relatively simple, even by passing a finger, to see the gap that occurs clinically, or even by flexing the knees, how the foot completely loses tension in slight plantar flexion. Unlike the area of the rupture, the ultrasound diagnosis is performed in two axes. That is, we have to make a journey from the most proximal part, from the distal part of the gastrocnemius to the very insertion in the calcaneus to visualize this fibrillar structure about 4 or 5 millimeters wide to its very insertion in the most distal portion of the calcaneus, and then subsequently perform the same exploration at 90 degrees to carry out the same maneuver. From the point of view of movement in the short axis, ruptures, unlike the physiological fibrillar pattern with these fibroadipose septa of collagen that occur inside the tendon, what it shows us is a clearly hypoechoic area, an absence of fibrillar pattern with thickened edges, sometimes even the stump itself visible, refract artifacts precisely due to the alteration of the physiological arrangement of the collagen fibers, with a paratenon that is practically always intact, an interposition of fat or hematoma inside the rupture, and generally associated with phenomena even of previous tendinopathies. An element that can lead to confusion, especially in ultrasound diagnosis, is the migration that occurs from the plantaris towards the central area. A plantaris tendon that remains practically always intact, and that, depending on its thickness, can lead to a certain sensation that there are certain fibers and that it is a partial rupture. When it is a complete rupture, this mechanism must be taken into account, because even in ankle flexion extension, we will be able to see certain fibrillar movement that corresponds precisely to these intact plantaris fibers. From an ultrasound point of view, another very frequent finding is the interposition of Kager's fat pad. When the entire tendinous structure is ruptured, more fatty material can interpose inside the rupture, which can confuse us, especially in static images. This is easily corrected by doing dynamic studies where the rupture itself can be seen much more clearly. We see in dynamic movement how even in more proximal areas we see how the stumps clearly separate. This can be done with or without anesthesia, but the diagnosis, I insist, of the rupture by ultrasound is frankly simple. From the point of view of ultrasound, certain findings are important to us. First is the ecostructure of the tendon itself. It should be noted that in a histological study of 152 Achilles tendon ruptures many years ago, it was found that 72% were associated with previous tendinopathies with or without pain. In fact, pain does not necessarily accompany this tendinopathy in cases of Achilles tendon ruptures. In these cases, we see very marked tendinous thickening and generally even ecostructural alterations inside the Achilles tendon itself. From the point of view of ultrasound, it is also important how far the rupture is, because it will often determine different treatments. Thus, we clearly differentiate ruptures in the insertional or distal portion, which are the least frequent, from ruptures in the body itself, which are by far the most frequent, and from proximal ruptures that occur in the already intramuscular area, that is, where we still have a component of the soleus that will make the retraction of the tendon much less. The pure tendinous zone, properly tendinous, which is the free tendon, the Achilles tendon, where there is no longer any muscular coverage, extends over a few centimeters, is by far the most frequently affected area. With this, we differentiate a proximal rupture, an intermediate rupture, and a pre-insertional or distal rupture within the three major groups of classification of Achilles tendon ruptures. Another element that is very important and that ultrasound will help us a lot with is the topographic approach of the sural nerve. It should be noted that from the external retromalleolar area, the sural nerve then subsequently crosses over the Achilles tendon. The identification of this nerve is relatively simple because it is accompanied by the small saphenous vein, and this location will allow us to do a prior mapping even before surgery to know exactly where the sural passes, considering that in older people of short stature women it can be located very close to the tendinous rupture area and thus be at risk in cases of percutaneous sutures. But probably the most determining factor from the point of view of the ultrasound study is knowing whether there is contact between the stumps in the rupture area or not. It should be noted that the closer the stumps are, and in this sense the ideal would be less than 1 millimeter of separation, especially in ankle flexion, the result will be better in conservative treatments especially. Not so if there is a separation of the stumps even of more than 5 millimeters in flexion. We know that the results are quite worse from the point of view of conservative treatment. With this we can end in this classification by Amlan made many years ago, but a very long series of more than 200 injuries establish very clearly where the rupture is, whether there was contact of the tendons at 20 degrees of flexion of the stumps, and even whether there was an interposition of fat or, well, from some hematoma among the stumps of the tendinous stumps themselves. Therefore, this situation is probably the most important in ultrasound from an exploratory point of view. Thus, we perform the ultrasound in a normal position and then move to a plantar flexion of 20 degrees to observe the behavior of the stumps, and in this regard Amlan has already established the criterion of the section in the area of the injury. But probably the most decisive aspect from the point of view of the ultrasound study is knowing whether there is contact between the stumps in the rupture area or not. It should be noted that the closer the stumps are, ideally less than 1 millimeter apart, especially in ankle flexion, the better the outcome will be. In treatments, the prognosis from the treatment perspective could lean more towards conservative treatments or more towards surgical treatments, depending on the separation of the stumps. We see it here in its classification into 5 types. Type 1 would be the injury where the stumps are relatively close, with more than 70% contact in plantar flexion, as we see in this case, where the prognosis is logically relatively better. Type 2 would be those complete ruptures where the stumps approach but do not contact more than 70%. That is, in this second type case, the contact is approximately half, between 30 and 70% in plantar flexion, with a slightly worse prognosis, but logically with a good response to a possible conservative treatment. Type 3 would be those where there is practically no contact. There is a clear separation between the stumps, as we see in this case, this stump clearly separated from this stump, which is more thread-like, much thinner, and with a frankly significant separation. Here we understand that the contact of the stumps is very small, and the prognosis in this case with conservative treatments would be clearly worse. Type 4 are ruptures with even much better prognosis because they are ruptures that occur still in areas where the soleus clearly contributes muscle, and are ruptures that unless dynamic explorations are done, we will practically not see them. They have practically no retraction, since the muscle still keeps the tendon close to the proximal stump, so in these cases dynamic exploration is mandatory. We see here how the morphological aspect of the tendon is practically normal, slightly thickened, but the mobilization of the stumps shows us how the stump separates from the distal portion of the proximal portion. Type 4 ruptures are frankly infrequent, as we have already said, even less than 5%. They are ruptures that occur less than 2% from the anterosuperior edge of the calcaneus. They are ruptures that very frequently have associated distal insertional tendinopathies, as in this case where we see certain fibers that remain and a complete rupture due to degeneration of the rest of the proximal stump. They are also ruptures that are difficult to perform an end-to-end suture on, and in these cases we tend more to do a refixation and transosseous in the distal area if necessary, depending on the characteristics of the rupture. In any case, what we often face when dealing with an Achilles rupture is first whether the case is surgical or non-surgical, and if it is surgical or we decide it is surgical, whether we could do it with conventional surgery, minimally invasive surgery, or percutaneous surgery. What we are going to analyze is whether the ultrasound really provides us with information to answer these questions and what science really contributes. The literature reviews regarding publications on this issue the answers to these questions. For this work, we have reviewed 49 references, of which 11, including systematic reviews and clinical trials, had a relatively high level of evidence A or B. A high-quality systematic review even shows that the fragility of the studies that have investigated this topic is very high, and furthermore, we have not yet found clinical trials that clearly compare open surgery and minimally invasive surgery. There are some suggestions that seem clear, such as that Achilles tendon ruptures cause a permanent deficit in muscle strength in all treated injuries, although their clinical relevance is not yet very clearly defined. A study, a good quality clinical trial, although a bit old, from 2011 suggested at the time that plasma was not useful for the treatment of acute ruptures, and from the point of view of comparing surgical treatment with conservative treatment, despite relatively short follow-ups, less than 3 years, 2 systematic reviews and a clinical trial found what seems to be already establishing itself as a paradigm, which is that ruptures or re-ruptures are more frequent in conservative treatments, and yet surgical treatments have fewer re-ruptures but more complications, something that seems logical. There is an interesting work from debut in 2019 that especially studies re-ruptures, the rate of ruptures, and in the different treatments, specifically in conservative treatments, which is a conservative treatment, but with early mobilization, has an average re-rupture rate between 7.25 and 11%, but which, however, can reach, in the case of early mobilization, 21% in maximum cases or 5.71 in minimum cases. So we clearly see how the problem that arises is going to be in conservative treatment is precisely going to be the re-rupture rate. From the point of view of the literature review, the separation of stumps is probably the most important element, but even in a fairly recent study by Hansen, which focused precisely on selecting treatment based on the size and separation of the stumps, they made an algorithm described in the slide, but they did not see, even in the case of patient selection, very clear differences, and the differences in surgical and conservative treatment were not significant, which slightly breaks the feeling we have that patient selection based even on the morphological type of rupture, in their case at least, did not determine very clear differences. More details of this literature review in the long term suggest that fascia flaps, as proposed by Silf, did not provide an advantage in this study by Heikkinen. Another study by Jones, also somewhat old, supported that surgical repair was associated with more infections, which logically seems obvious on the other hand, and that the use of percutaneous techniques reduced the infection rate. This is clear. It does seem that the use of surgical material is important in the sense that absorbable suture ruptures have fewer complications than non-absorbable sutures. And finally, that percutaneous repair, and this is a well-documented fact, very common in different publications, increase the risk of sural nerve injury, with ultrasound being precisely one of the elements that will provide us with clear added value in the sense that it will be able to clearly identify the topographical situation of the sural nerve. Regarding rehabilitation, there are also controversies. A systematic review and a good clinical trial study concluded in favor of rehabilitation protocols with early mobilization and loading, which is somewhat in contrast to the rupture rate provided by Wu in his study. And a clinical trial also of good quality, comparing open surgical, percutaneous and conservative treatment with the same postoperative protocol of plaster for 10 days with a boot, with wedges for 6 weeks and early loading at 8 days, did not differentiate re-ruptures because they did not find any, and with similar treatment efficacy, which advocates for treatment with relatively early rehabilitation. With all this, and returning again to our initial question, which is the best, whether orthopedic treatment, percutaneous surgery, open surgery, orthobiological treatments, we can say as a conclusion from the initial point of view that none of the recommendations is strong. That is, most of the recommendations are inconclusive, and on the other hand, two moderate recommendations only advocate for protected early loading and protected postoperative mobilization. So we see that the evidence, unfortunately, despite a very common injury, is that there is not so much evidence in this regard. There is indeed a very interesting study in '93 that precisely studied non-operative treatment with surgical treatment. It precisely focused on these two aspects, the differences between surgical treatment, which had higher infection rates and a greater ability to return to the same sporting level, although we have already seen that there are many publications that say that full previous strength is never reached, and on the other hand, conservative treatment with higher re-rupture rates, with greater loss of strength, and with a tendinous elongation that on average is established at 2%. We continue with our doubt to operate or not to operate. If today ultrasound provides us with prognostic variables that help in this decision making. Within all this information that we have been seeing, probably the contact of the ends between the different stumps will at least serve as a support guide. In the study precisely of 273 patients conducted by Amlan, he made this classification, and from the point of view of the classification, he saw that the initial acute treatment of less duration from the diagnosis of the rupture to the treatment in acute injuries, which in his case reached up to 80%, made the treatment, the cases with a good position of the stumps, which reached up to a quarter of the number of patients with functional treatment, had a good solution from the point of view of the result, acute ruptures with a 50% apposition of the stumps, or the other 50% depending on whether or not there was interposition of fatty material, which is what differentiates letter A or B, also lean towards functional treatment or percutaneous suture, while we already see in those cases where the separation in his study of the stumps with absence of contact inflection, or those cases already of more chronic ruptures. Of 4 weeks duration, which in his case As we see here, approximately a quarter of the cases were dedicated or had to be addressed with more aggressive treatments such as open suture or even interposition grafting. So we see that in his study, at least in a frankly broad study, he gave a lot of importance to the degree of contact of the stumps and especially to the earliest possible treatment. These results of Amlan are relatively validated by a study by Carmon, also a bit old, 2011, but which saw that percutaneous treatment produced clear improvements. But that the greatest disadvantage of percutaneous repair is that it cannot ensure the position of the tendinous stumps. So the use of visualization methods improved the results. So we again emphasize that possibly a repair from a minimally invasive point of view, but with maximum visualization of the position of the stumps may probably be the future treatment of Achilles tendon injuries. In this sense, the aim of the treatment would be to minimize morbidity, but by approximating the stumps, as we see in this slide. That is the anatomical concept from the point of view of understanding what we are talking about, a tendon that slides and moves within a closed compartment, which is the external compartment. So one of the most important elements would be to allow this mobility of the tendon in relation to its own fascia that covers this superficial compartment. The mechanical concept where the ends must be approximated so that they heal without elongation, which is one of the major complications of conservative treatment. And finally, the biological concept, which is to preserve as much as possible the reparative process initiated in the rupture from the injury. Ultrasound-guided sutures will allow us to approximate and unite the stumps, thus answering this biological doubt because we do not use surgical approaches. Type 4 are frankly infrequent ruptures, as we have already said, even less than 5%. They are ruptures that occur at less than 2% of the anterosuperior edge of the calcaneus. They are ruptures that very frequently have associated distal insertional tendinopathies, as in this case where we see certain fibers that are maintained and a complete rupture due to degeneration of the rest of the proximal stump tendon. They are also ruptures that are difficult to perform an end-to-end suture, and here in these cases we tend more to do a refixation and transosseous in the distal area if it proceeds depending on the characteristics of the rupture. In any case, what often arises when we are faced with an Achilles rupture is firstly whether the case is surgical or non-surgical, and if it is surgical or we decide it should be surgical, whether we could perform it with conventional surgery, minimally invasive surgery, or percutaneous surgery. What we are going to analyze is whether ultrasound really provides us with information to answer these questions, and what science truly contributes to the literature reviews regarding publications on this issue, the answers to these questions. For this work, we have reviewed 49 references, of which 11, including systematic reviews and clinical trials, had a relatively high level of evidence A or B. Thank you very much for your attention.